Hi everyone. Today we're going to be, sorry, there was a dramatic pause there. Today we're going to be talking about elimination. A lot of the medications that we're going to be talking about today, you guys are fairly familiar with, but I kind of want to do a deeper dive into many of these common meds and especially the adverse effects and our nursing considerations on each one. So without further ado, let's get into it. The first medication we're going to talk about, classification, and the only classification in this is antidiarrheals. The only medication that we're going to talk about, I should say, in antidiarrheals is the prototype loperamide, better known as Imodium. I don't want to get personal, but I feel like at one time or another, most of us have taken this medication, but maybe we didn't know as much as we should know about Imodium, especially if taken in high amounts. So what is the indication for Imodium or loperamide? Indications will be for non-specific diarrhea, chronic diarrhea, especially in the cases of irritable bowel disorders, or traveler's diarrhea. You know, you go into any drugstore, you go over to the travel little section and grab your little carry-on shampoo, conditioner, lotions, and there, behold, is Imodium, which is very effective, especially when you're traveling outside the country. You're eating foods that your system might not be used to, you might be sensitive to, you develop some diarrhea. It's not necessarily of an infectious nature, hopefully not. So Imodium is definitely very effective in these situations. So how does Imodium work? It's very interesting because, you know, we've talked about opioid receptors, we've talked about opioid agonists, antagonists. In the comfort lecture, we talked, not comfort, well, in comfort as well, but addiction lecture, we've talked about, we will talk about how the receptors work in our bodies. In this situation with Imodium, it actually directly works on the opioid receptors in the large intestine. Yes, we have opioid receptors in the large intestine. And so like any opiate or narcotic, if those opioid receptors are triggered and covered, it's going to slow down motility. You know, what have we always said about narcotics? You know, taking pain medication in the hospital and the education with our patients is, you know, we got to, you know, if you need the narcotics, which you know they do for pain medication or pain management, we want to get them up and walking. We want to make sure they're drinking enough because it's going to slow down their intestinal motility. And many people taking narcotics for pain management develop constipation, so we don't want that. So in a way, kind of bringing this full circle, that's how morphine works. Yeah, that's how Imodium works. So essentially, it's an opioid receptor agonist. So this one's an agonist similar to morphine, but it specifically targets the opioid receptors, like I said, in the walls of the large intestine. So by doing this, it decreases motility. Kind of interesting. Given in low, very, very low doses. It's not even considered controlled or narcotic when we're pulling it from the Omnicell. So with all that being said, what are the ADRs of this? So the adverse drug reactions or the adverse effects is mostly cardiac and descent. So taken in high doses, hopefully not with the intention of overdosing, but many people who have diarrhea, it reminds me of some other medications that we've talked about that they'll just pop like Tic Tacs without consideration of any adverse effects. But if they take Imodium in high doses to try to manage their diarrhea, which, you know, you can't fault them for that. It's a terribly uncomfortable situation to be in to have diarrhea. But it affects them cardiac. So it actually goes, you know, it blocks the opioid receptors, but in high doses, it blocks the ion channels in the heart. So we've, you know, or what we have or will learn about the potassium channel blockers, the sodium channel blockers, the calcium channel blockers. So this further blocks channels in the heart between potassium, sodium, and calcium, and with that, they can develop cardiac dysrhythmias, torsades. You guys will really get into that next semester and fourth semester with your cardiac arrhythmia teaching, and cardiac arrest. They can VFib. So that's something to be mindful and include in our patient education to really follow the guidelines, follow the directions on the box when you're buying it, and do not exceed the recommended dose. So nursing implications also is for many, whether it's an antidiarrheal or some others, Common side effects for this: dry mouth, dizziness, abdominal discomfort, constipation. And then again, if they feel any heart arrhythmias, palpitations, we need to educate them to call their doctor, or if need be, call 911. Do not administer with presence of bloody diarrhea. For many reasons. Bloody diarrhea, we need to kind of do a deeper dive into what's going on with the bloody diarrhea, especially if it's not, symptomatic hemorrhoids. Do not administer with temp greater than 101 Fahrenheit. And why is that? Because if they have a fever, then this diarrhea may be due to an infection, whether it's a viral or a bacterial. So we don't want to just keep stifling and taking Imodium and stopping the diarrhea when we need to find out the deeper reason of the cause of the infection. If there is an infection brewing, encourage fluid intake with any situation. When someone's having diarrhea, obviously fluid and electrolytes are a priority concern. And report diarrhea greater than 3 days. I'm taking Imodium. I've had diarrhea for 5 days. I need to call my provider. We need to figure out what's going on further than just your basic non-specific diarrhea. Okay, so that was the long and short of the antidiarrheals. There's some others, of course, that we give in the hospital that I'm not going to get into. Let's just stick to that one prototype, which the textbook mostly focuses on. But now let's get into laxatives, which are extremely common in our patient population for many reasons. We're talking pharmaceutical industry. Many pharmaceuticals induce constipation. Many situations do. Our patients are in the hospital setting. They are laying in bed. If I've said it once, I've said it 100 times for our patients. It's not typical that you're laying in bed all day. I'm sure you're much more active at home, but with inactivity comes constipation. So with that being said, how about we get our patients up and out of bed at least a few times a day? And we need to kind of combat that complacency to just let our patients eat in bed, let our patients lay in bed, just turn in position when they are otherwise very active. So we need to promote activity. So without further ado with this, let's get into it. So we're going to talk about chemical stimulants, osmotic stimulants, bulk stimulants, lubricants, GI stimulants. So laxative indications, painful elimination. We're talking hemorrhoids, episiotomy. Boy, yes, they not only need pain medication, especially for hemorrhoidectomies or episiotomies, pain medication plus laxative. We don't want to create any more pain than they're already in. Vagal stimulation. We don't want straining for certain patients of ours, especially cardiac. For the elderly, laxative indications because they have decreased muscle tone, which is kind of age appropriate. Again, activity is key for all of these patients. Procedure prep, we're going to talk about the Go Lightlies of the world, and then decreased mobility. That just kind of solidifies my point. Move our patients, please. All right, so the first one we're going to talk about, chemical stimulants. The prototype bisacodyl, also known as Dulcolax. Many of us have administered Dulcolax to our patients. Now you're in 3rd semester. You're able to administer suppositories. Not a fun, method, but it's very effective for our patients. So indications for Dulcolax: constipation, colonic evacuation, pre-procedure examination. So oftentimes this is a complement therapy. Dulcolax is used in combination with Dulcolax pills. Dulcolax suppository, I should have started with Dulcolax suppository, maybe with Dulcolax PO, maybe combined with a Milk-O-Meg or Go Lightly for prep, whether it's somebody has to go for a colon resection or colonoscopy. So how does it work? What's the action? It has a direct effect on colonic smooth muscle by stimulating the intramural nerve plexi. We're going to talk about plexes in a couple different ways here, but essentially it just promotes fluid and electrolyte accumulation in the colon. The more fluid and electrolytes it kind of pulls in, especially the fluid, increases peristalsis, right? Seems pretty straightforward, which it is. Okay, so let's talk about the adverse effects of Dulcolax or bisacodyl. I'm just going to stick with Dulcolax because it's better known as Dulcolax to us and our patients. Excuse me. So adverse effects, what do we need to consider? first of all, the expected results, which are not fun, are expected results. Okay, we're not going to stop giving Dulcolax because they have bloating, which we can expect, because they have cramping, because they might be nauseous. We're hoping for movement. So sometimes this movement can come in the form of diarrhea. Oh shoot, they have diarrhea, let's stop. It depends. Okay, so it depends on what we're giving the Dulcolax for. If it's for a prep, we want to give any type of prep until the intestinal contents are clear. All right, so how many times if we sent somebody down for a colonoscopy and they attempt to start the procedure and the GI doc says send them back up, they need to still be prepped because it's not clear in there. So but in the presence of appendicitis, diverticulitis, ulcerative colitis, if any of these folks are going to surgery, we need to be much more aware of how this is going to affect them. So oftentimes we don't need to do a full-on prep, obviously, if we're sending a patient down for an appendectomy. But if they are going down for intestinal resection, that's a different story. We still have to clear them. But with all that being said, if they're having bloating, nausea, vomiting even, which is pretty common with any of these laxative stimulants, we want to be sure that we have some type of anti-nausea med on board as well, so that we can give that. The Zofran, Compazines. Should we give Reglan? It depends. Remember, Reglan is an anti-nausea, but it works by way of increasing intestinal motility through peristalsis, right? So we just have to be aware of that as well. So heading into nursing applications, common side effects we just talked about, pattern of bowel activity. We want to know, how many bowel movements do we have? Are they clear, especially if they're going down for a scope or some type of procedure? Do not give with rectal bleeding for any of these. We don't want to be aggravating rectal bleeding any more than we have to. So we need to be really leery of giving laxatives and notify the provider if there's rectal bleeding. Encourage fluid intake with any of these. It's got to be said. I know some of this, as in any other lecture, it's repetitive when we're talking about various prototypes in the same classification or similar classifications, but encourage fluid intake. Why? Because any of these have the potential to decrease or affect the electrolytes and causing electrolyte imbalance. So report unrelieved constipation. Do not take with antacids or milk. And this is often given perirectally by way of suppository and or little Dulcolax tabs. Boy, when you pop out a little Dulcolax tab into the cup and you see how little it is, it's amazing. It really packs a punch and it is very, very effective. Back to milk, I wanted to touch on that, or antacids. You're popping, these patients are not feeling so hot, they're taking Dulcolax to help their constipation, but they also feel a little indigestion, their stomach hurts, they're nauseous, so they're going to pop some Tums as well, or drink it with milk. I got to drink some milk to settle down my stomach. Boy, I just felt like I was talking too fast. Slow it down, Joe. So why do we not do that? Dulcolax actually, they're enteric-coated tablets. So number one, they shouldn't be crushed. But number two, when you take an enteric-coated tablet like Dulcolax and the expected spot that is supposed to work is down in your small and large intestine, the enteric is purposeful so that it doesn't start to break down and dissolve in your stomach. So if you take milk or antacids with an enteric-coated Dulcolax tablet, it starts to break down the Dulcolax in the stomach. First, it takes away from the effectiveness because it didn't reach the intestine and it just dissolved in the stomach. And second, if Dulcolax dissolves in your stomach, it really causes indigestion. So just note that. Stay away from antacids or milk, as with any other med, at least 1 to 2 hours separation from taking the Dulcolax. And here is a friendly picture of how to administer the suppository. Hopefully, many of you have already done this. If not, this is a nice illustration. All right, now let's go on to another stimulant, a chemical stimulant. The prototype, the next one we're going to talk about is Senna. So generic Senna, brand name Senna Cot. So oftentimes we think about pharmaceuticals, big pharma and everything else, everything's synthetic. This is one of the few that is FDA approved and herbal. I love it. I love it, and it's been working for years. Senna is from a plant, a tropical plant. This has been used for centuries. The chemical, what is it, senicides, I think it is, derived, senicides, which is derived from this plant. And like I said, it's just a natural occurring laxative. It's very neat. They've been using it for the entire human story. And I always say, hey, if it's being managed, yes, FDA is giving it its stamp. We don't want to go overboard with administering it to ourselves, but if we follow the directions, it works extremely well. So, and I only say that because some people with all herbal is just wonderful and it's so good for, it is, but it's got to be managed. Anytime you're doing something herbal, you always want to touch base with a comprehensive, holistic person who might be an herbalist or a naturalist. So back to indications. So the indications for Senecot, short-term relief of constipation. This can be found over the counter as well. Colonic evacuation pre-procedure examinations. Yes, textbook says that as well. I've never given Senecot for a pre-procedural prescribed regimen. Actions, so it has a direct effect on the colonic smooth muscle by stimulating the intramural nerve plexi. There we go again with the nerve plexi. All right, adverse effects, very similar to other stimulants. This is actually verbatim, not to be given in the presence of acute abdominal disorders such as appendicitis, diverticulitis, bowel obstruction, or ulcerative colitis. That's right out of the textbook, and it's definitely good to be aware of. Nursing implications, similar to others, but much less. I mean, especially for the elderly, Senecot is such a wonderful laxative. Miralax, I know we give that nonstop now, but sometimes I'll just talk to my patients about going back to the naturals. But with this, common side effect can be a reddish brown urine, so that's good to include in the patient education. When your patients have this prescribed, note the bowel activity, encourage fluid intake, and just be aware, we don't want anyone taking this for years, kind of including the other dimensions of care, especially mobility and food. Some of these patients are eating foods that have a tendency to be constipating. So we want to talk to them about a more comprehensive diet as well. All right, let's talk about our next laxative in the form of bulk. So a bulk forming laxative that we're going to talk about today is very common. Prototype psyllium. Speaking of natural, this is another natural, I think it's from, I don't know what the nut or the fruit off of a tree is, but they take the psyllium and they grind it down into psyllium. It's a psyllium husk, and they grind it down so fine. This is another one that's been used for centuries. And we have marketed it now over the past 50, 60 years. And so better known as Metamucil. So the indications for Metamucil, it's a bulk forming laxative. It treats occasional constipation. And it's also a dietary fiber supplement. So there's a lot of fiber in that husk as well before they grind it down, or, not even before it's, there's a lot of fiber in the husk, the husk. Is it hull or husk? Anyway, so how does it work? It dissolves and swells in water, providing increased bulk, moisture content, and stool. All right, has anyone ever taken Metamucil before? It's kind of interesting. I will self-disclose that there was a nurse on 5 South who stated that he was on the Metamucil diet. Well, I looked it up and it was like, lose 10 pounds in 15 days. And I was like, oh man, that's for me. I'm going to do that. And so it's it's the Metamucil challenge. I don't know if any of you guys have done it before. Pretty interesting. But boy, oh boy, do you need to drink lots of water. And it's really interesting. Sometimes when I would mix it up in my little shaker bottle and then forget to mix it, I would see something on the bottom that was like a 2-inch glob, and I open up my shaker bottle, kind of stir it with a spoon, and it sets up. It is very interesting. It's very mucilaginous, kind of like a slippery elm. But if you don't, so Metamucil works both ways. If you're not going to drink enough water or fluids with it, you can become constipated very quickly. So the biggest key to patient education with patients taking Metamucil is drink plenty of fluids. All right, so ADRs, textbook, Same as the previous meds with my extra, make sure they're drinking a lot of water so they don't have bloating and constipation because they're not taking in enough fluid. So nursing implications with that being said, abdominal discomfort, monitor for bowel obstruction because of that, encourage fluid intake because of that bowel activity. We want to make sure they're having a BM. If this is not going to work, we need to switch to something else. You can mix the powder with water or juice. Always, always, always ask the patient what they would like to mix it in. In the event that there's allergies to something we might be mixing, can be taken daily, and it's over the counter. Okay, let's go on to the next one. So the next classification we're going to talk about are osmotic laxatives. Osmotic laxatives, not bulk. The prototype we're going to talk about is magnesium hydroxide, also known as milk of magnesia. So the indication is treatment of short-term constipation. And the action, how does it work? Well, it's an osmotic effect. So it works, it pulls water in, primarily in the small intestine, draws water into the intestinal lumen. Hence, I love saying the word hence we have increased movement. Okay, so I just noticed there's bulk stimulant. It should be osmotic stimulant. Milk of mag, osmotic stimulant. I'll fix that before you guys look into this. So ADRs is a little different than our previous laxatives. So magnesium is cleared via the renal system. So we need to make sure that we use caution in patients with renal insufficiency. Nursing implications for milk of mag. And going back to that, I just want to kind of elaborate a little bit more on that. So say you are renal insufficient. Say there's some renal failure there and you're taking milk of mag. If magnesium is cleared via the renal system, what happens? We have a decreased clearance, right? And hence, I love saying hence, magnesium levels might increase or decrease in your body. Increase if there's decreased clearance, right? We're not able to get that magnesium out. All right, so magnesium, the situation might turn into a hypermagnesium situation. And what does magnesium do, especially to your heart? It can throw you right into heart arrhythmias. Very high magnesium, actually, you develop torsades, to points, which is a lethal arrhythmia. So again, you guys will learn about that next semester. I love teaching cardiac, which wish I could elaborate more on that, but good to know with milk of mag. Think magnesium, think renal insufficiency, contraindicated. All right, so nursing implications for milk of mag, common side effects, cramping, diarrhea, flatulence. Again, we're talking about laxatives. Unfortunately, these are accepted downsides or accepted side effects. Contraindicated in renal failure, there's that. Bowel activity, we need to monitor that, continue. Encourage fluid intake, and only use for short term, especially going back to if our patients have predisposed cardiac situation or disorder or syndrome in any way, probably not going to be looking at milk of mag. Again, think renal, cardiac, any predisposed disease processes, we need to be very mindful of probably not using milk of mag for a laxative. Okay, so the next osmotic laxative that we're going to talk about, the prototype is polyethylene glycol electrolyte solution. So go lightly, and also Miralax. So I've included Miralax too. It's very, very common, right? So Miralax, how does that come? How do we administer that? It comes in the form of those little packets in the Omnicell, right? And that is polyethylene glycol. So that's Miralax. Go lightly is polyethylene glycol electrolyte solution. And that's key to know as we kind of go into this. So what is the indication? Miralax is given probably most commonly in the hospital for constipation, especially with our elderly population. Very gentle on the system. Go lightly, those big gallon jugs that need to be mixed with water to dissolve. It's for bowel cleansing before a GI examination or colon surgery. All right, so essentially bowel prep. So how does it work? The action is osmotic, again, as it's classified. Draws more water into the GI tract, thereby stimulating increased GI motility. Okay, so adverse effects are pretty similar to other laxatives. Again, this is a osmotic stimulant. I see the header up here as bulk stimulant. I'll get that changed. before class. I don't know. Anyway, so adverse effects, GI effects, diarrhea, abdominal cramping, bloating, nausea. I've talked about this with almost every single one of the laxative we've talked about today. And it's expected. It's not comfortable. It's, very uncomfortable. So we need to make sure that we have symptomatic medications in the event that they have nausea, especially. Do we want the diarrhea? Yes, this is a colon cleanse. Abdominal cramping comes with it. May have to give a pain medication. Let's try to steer away from narcotic because it's going to slow down the GI motility. So let's try to find creative ways to provide pain relief, especially in the non-pharmacologic. So if a patient's getting a bowel cleanse for prep for a procedure, for surgery, a great non-pharmacologic is a warm pack. We need to get an order, always get an order for a warm pack, but boy, does it do wonders. Nursing implications for anybody taking GoLytely or Miralax. Note the bowel activity, especially if they're doing GoLytely. We need to ensure that the bowel movements are clear, literally clear, before they go down for their procedure or surgery. God forbid we send them down and they're not prepped correctly and they have to come back up and there's delays, and that adds more issues, right, and problems to a hospital stay. No oral meds within 1 hour of start of therapy. Why is that? Say I'm taking my antihypertensives and I start taking GoLytely. It can kind of speed things through before they're absorbed and effective in my system. Replaces electrolytes lost. So that is, sorry if you just heard my email thingy go off. GoLytely has electrolytes in them, so we don't need to replace the electrolytes on top of the GoLytely that they're already taking. The GoLytely itself is 4 liters, and the patients are encouraged to drink a cup or 240 milliliters every 10 minutes until consumed or until fecal contents are clear. That is an absolute must. Okay, let's talk about one of the most common, not laxative. I want to be clear, Colace is not a laxative. How many times have I been in a patient's room with a student and the student says, I have your laxative Colace here. Okay, thank you. It's not a laxative. It's a lubricant. How we describe it to patients in more layman's terms, I have your stool softener, which essentially it's really not that either, but that's how we describe it to our patients rather than laxative. And most of our patients are familiar with Colace. All right, the brand name, the prototype that we're going to talk about is docusate sodium, brand name or trade name Colace. All right, indications for constipation, mostly, but it's not a laxative, but it does help with constipation because of its lubricant nature, but mostly ordered. I can't even say this because I feel like every single patient, whether it's for straining or not, but it's indicated textbook for reduced straining. So how does it work? Action decreases the surface film tension by mixing liquid with bowel contents. Establishes hopefully a slippery slope. The adverse effects of Colace, it can be diarrhea, abdominal cramping, bloating, dizziness. All right. If our patients are experiencing diarrhea, I've had many a student kind of stop, use their critical thinking, ask the patients, when was your last bowel movement? Oh, I've had 3 loose movements, in the past couple hours. And geez, whatever you guys are giving me is really working. So in those situations, of course, we're going to hold the Colace, talk to our cover nurse, report it to the provider, and maybe change medication regimens if needed. So who gets this? We have the elderly population that gets their Colace. It's very prevalent, popular in the postpartum population. Yeah, and then again, nursing implications encourage fluid intake. That's going to help relieve constipation. Some of these other non-pharmaceutical, pharmacological approaches and interventions we need to consider and include as well. Sometimes we're so medication focused as students and nurses that we forget to look at the bigger picture here. Increase their fluid intake. Every time you're in your room with your patients, have them take a drink of water. They not only need oral care because their mouth and their lips are so dry, that's got to tell you probably a little on the dehydrated side. Increase the motility, increase mobility. Back to nursing implications, We have to know their bowel activity. And then, of course, because it's essentially not a laxative, it should not be prescribed, especially solely to treat constipation. Your patient has not had a BM in 5 days, which it seems all too common in the hospital that I hear that from my students. When was their last bowel movement? About 5 or 6 days ago. Our radar should go up. We need to help these patients. Again, the epicenter of your immune system is your intestine, right? If our intestine is working well and effective and moving things through and helping to excrete, you're going to be healthier. So we need to stay on top of when was your last bowel movement. All right, so that kind of shifted from bowel to now we're going to talk about, we're going to get back to, let's just shift to our medications that affect our male population and male and female population with our antispasmodics. So the first thing we're going to talk about, a couple of meds that affect BPH. What is BPH? Benign prostatic hypertrophy. And so the first medication that we're going to talk about, the classification, is an alpha adrenergic blocker. That sounds cardiac, doesn't it? It sure does, because this is also used, both of them are labeled as cardiac and BPH. In this case, though, we're only going to be talking about PBH, PBS. BPH, so the prototype we're going to talk about is tamsulosin. I always trip up on this word. Tamsulosin, better known as Flomax. So you see tamsulosin, it's a male patient that you're giving this to. Still have a conversation. Do you know why I'm giving you Flomax today? Oh yeah, I have a prostate issue. Some patients, this is a sidebar, nice to know, good to know, not need to know for the exam. Female patients receiving tamsulosin would be indicated for cardiac. All right, blood pressure. You want to lower their blood pressure. It seems to work for the female patients. So I had a student, some of you guys know the story because I've had you in clinical, but I had a student one time go in and they were discussing patient education with their patient on their medications, and they get to Flomax, and the student said, and you're receiving this Flomax for your benign prostatic hypertrophy. And she was talking to a female patient. And the patient looked at me and said, my prostate? And I said, oh, she's actually receiving for her blood pressure. But in the event that this is being prescribed for males, most oftentimes, 99.9% of the time, it's for their BPH, okay? It's for their prostate, their enlarged prostate. So indication in this situation, in this case, treatment of BPH. Action, how does it work? It blocks the postsynaptic alpha adrenergic receptors, which results in a dilation of arterioles and veins, and a relaxation of sympathetic effects in the bladder and urinary tract, which includes that prostate, as that urethra is going right down. That's all part of the urinary tract, so it's going to impact the prostate as well, which is connected to the urinary tract, and help to relax that as well, not be so constrictive on that urethra, which is creating urinary retention in our gentlemen, and we want to relieve that and help them urinate better. These are the patients that we talk to that say, you're 55 years old, when you're standing at the toilets, do you feel like it's taking some time for your flow to start? Oh yeah, I'll be standing there sometimes 2 minutes before I'm able to urinate. That tells me that they have an enlarged prostate and that they might need to be referred to a urologist, all right, to take a look at that on many levels, not just to prescribe a medication, okay, especially if they have history in their family of prostate cancer. We don't want to start with an enlarged prostate and just assume it's benign. All right, so with that being said, adverse effects of Flomax, they can develop headache, they can develop fatigue, they can have dizziness, lethargy, tachycardia, hypotension, maybe some GI upset. Many of those are expected. Headache you can treat with Tylenol in the event that they have headache. Fatigue, ensure that they're getting proper rest. Dizziness, encourage them, if you're feeling dizzy, please sit down. Tachycardia and hypotension, though, they've got to keep an eye on that. We have many patients on tamsulosin for their BPH. And I can't say that these are common side effects. These are side effects that I actually rarely see with patients receiving Flomax. Nursing considerations for this population receiving Flomax for BPH, use with caution with patients who have heart failure or heart disease. because we're talking about an alpha adrenergic blocker. This is not a beta blocker, it's an alpha adrenergic blocker. And I'll talk to you guys more about this if I haven't already with our perfusion lecture. So use with caution with patients who have heart failure or heart disease, which could be aggravated by the drop in the BP or the tachycardia. Okay, we don't want them to bottom out. We don't want them to slip from a tachycardia into a dysrhythmia. So, and then with that being said as well, only makes sense, there's an increased risk when used with other antihypertensives. If I'm taking lisinopril, which is an ACE, that's dropping my blood pressure, and then I take a Flomax, which is an alpha adrenergic blocker, just bear with me. I know this is heavy. Some cardiac stuff is heavy, and I'll make it more simple as I teach throughout the course. But essentially, at the end of the day, you don't want these patients bottoming out because he's essentially on 2 antihypertensives, okay? So big things to keep in mind when your patient's receiving Flomax, which seems like a benign drug for a benign issue, but it can really affect the cardiac. The next, we're going to talk about that treats BPH, which does affect elimination in the urinary or urination department, is 5-alpha reductase inhibitors. All right, the prototype is finasteride, better known as Proscar. All right, so Proscar is ordered for the treatment of BPH. How does it work? It inhibits the intracellular enzyme. Again, this is like a chemical formula. Good to know. You don't have to know this for the exam. Inhibits the intracellular enzyme that converts testosterone to a potent androgen that the prostate depends on for its development and maintenance. So if you're blocking that enzyme, excuse me, that converts the testosterone, without Proscar, let's put it this way, without Proscar working, the intracellular enzyme that converts testosterone to a potent androgen that the prostate depends on for its development, that enzyme is just going to help the prostate stay larger, healthier, the body thinks at least. But in this case, we have an enlarged prostate. We don't want to be essentially feeding that anymore. We want to almost decrease the size. So this, the 5-alpha reductase inhibitor in the form of Proscar, is going to inhibit that enzyme from converting testosterone, which would help to continue to develop, not only develop, but help keep that prostate at the size it is, which in this case, it's too large. All right, we have hypertrophy. So kind of an interesting, physiology here. Given that explanation, the adverse effects could be impotence, all right, decreased libido. And why? Because you're inhibiting the testosterone, right? The enzyme that converts testosterone to an androgen, right? So if you're inhibiting that, you could be creating an impotence. You do often hear patients say they do have a decreased libido because of that. It can cause some abdominal upset, some GI issues. Breast enlargement and tenderness, that kind of goes along with your blocking the testosterone converting to androgen, right? And then because of that as well, it all kind of goes together. Gynecomastia is pretty common with Proscar. So, some of this is physician preference, whether they choose Proscar or whether they choose Flomax. If you have patients that have predisposed cardiac issues, you're going to have a urologist prefer to prescribe Proscar. But you see there's downsides to both, right? So nursing considerations for Proscar, contraindicated, actually not indicated at all for female patients because of the androgen effects. And this is also a hazardous med. You guys have heard me talk about hazardous meds in the hospital. You might be like, geez, if I touch it with my bare hands, what's the worst that's going to happen? A lot of these meds, especially considered hazardous meds, rightfully so, absorb very quickly when they, touch your skin dermatologically, topically. So with that being said, anyone who's had me for an instructor, I always, and I noticed, especially when I'm doing validations for 105 and the PO, administering PO validations, it's not required to wear gloves. I tell all my students, and I do this, and I've done it for years, I wear gloves when I'm administering medications. That covers me for safety for hazardous meds. Actually, it provides safety for the patient as well. How many times do we pop out a pill? Oops, it fell down, and we have to pick it up with our bare hands, put it in the cup. I don't want somebody touching my pills that are going in my mouth with their bare hands. I just don't, especially in the hospital setting. So I always say, good rule of thumb, best practice, safety practice, please just wear gloves anytime you're giving pills. All right. I go in, I hand sanitize, I put on my gloves before I start doing any medication administration, because you never know what's going to happen too. Your medication administration, something else happens, you need gloves on. At least you already have them on. All right. So, but going back to ProScar, it is a hazardous med, so you need to wear medication. You need to wear gloves when administering it. All right, and the last thing we're going to talk about that affects the urinary tract, we talked about bowel. We've been talking about urinary tract the past few minutes here. Urinary tract antispasmodics. Prototype that we're going to talk about is oxybutynin, better known as ditropan. I have your ditropan. Oh, thank you. I have such bad bladder spasms. I don't know why. They haven't discovered why. A lot of times we know why, but sometimes when we don't know the etiological source, doctors will order ditropan for bladder spasms. Very uncomfortable feeling. Indication for symptomatic relief of bladder spasms, but also for treatment of overactive bladder, which many patients have. I just heard a stat this morning listening to, it was a very legitimate resource site, saying that on average, I'm going to guess it's more, I'm going to guess this is underreported, on average, the average American is on 4 medications a day. So talk about a pharmacological industry here. 4 pills a day. Thankfully, I'm not on any, knock on wood, but 4 is a lot. Anyway, many of our patients are on many more than 4, right? We know that. We're sitting there, our 10 o'clock in the morning med pass and giving 23 medications. It just blows my mind for these poor patients. How do we get to this point? But unfortunately, many of those medications, whether you watch the commercials, or you take my farm course, or you're just living and talking with people, especially your patients, many meds can actually cause overactive bladder. So again, this is like a symptomatic med to take care of another side effect from another medication. It's a tricky industry, and it's tricky trying to intercede with all these considerations, as a nurse for our patients. Anyway, moving along. The action of ditropan, it relieves spasms by blocking the parasympathetic activity, right? Kind of makes sense. Parasympathetic, fight or flight. You have to go to the bathroom really quickly when you have anxiety. Anyway, parasympathetic, so it's blocking the parasympathetic activity, thus suppressing overactivity, which leads to the relaxation of the detrusor, just a type of urinary muscle, or other urinary tract muscles. All right, so it's just relaxing the bladder. It's telling the brain, have everything calm down there. Okay, you only have 150 milliliters of urine in your bladder. Calm down. It's not, wait till you have fullness in order to urinate. All right, downside of ditropan, adverse effects. Our patients can be drowsy. They can have blurred vision. They may experience dizziness, tachycardia, dry mouth, nausea, urinary hesitancy, decreased sweating, maybe some angioedema. So a lot of this, ditropan, it can work with, it can have anticholinergic effects. And so many of those kind of point to that. And that's just how, I'm not going to go into it, but that's just how it kind of works in the brain on the parasympathetic response. Nursing considerations when patients are on ditropan. Ensure we don't want to just give ditropan if they have urinary spasms, right? If they have bladder spasms. Another telltale sign of an issue, maybe a urinary tract infection, your body is saying, have bladder spasms, get this bacteria out of my bladder as soon as possible. And if you have a doc or a provider that's just ordering ditropan because you have bladder spasms without identifying through a urinalysis or a culture and sensitivity that you have a UTI, we have a problem. So we need to ensure that the patient does not have a UTI before we proceed, or any other infection before we proceed with an antispasmodic like ditropan. Administer with food. It can have some GI effects. It does help to eat. That's nice to know. When your patients are receiving ditropan, monitor urinary output to ensure adequate renal function. You don't want the bladder to be too relaxed that we're not urinating as we should. So we don't want retention actually causing a UTI, which is actually very, very uncommon. I've never seen it with anybody receiving ditropan. Ditropan is such a great med, works so well. for our patients with bladder spasms or overactive bladder. And that wraps up the elimination lecture. Hope you guys have enjoyed listening to my annoying voice. Have a great day.